morning. My name is Sonia Laws. I'm a student at William Carey University. We're going to be doing our presentation on patient care, triage, and outcomes in a global pandemic in the United States and abroad. Joining me this morning is my colleague, Kelly Hollis. He'll be starting our first slide.
Good morning, everyone. I'm Kelly, and I'm an MSN student at William Carey University. So we'll go ahead and start with a brief introduction and look at our objectives. The objectives for this lesson will be affective, cognitive, and psychomotor. We want to qualify the value of care and resource distribution in the acute, clinical, and rural setting. So across the different theaters of care that the patient will need during their visit or any medical anomalies, we want to look at how we're going to use each of our resources in those settings. We'll describe advances in technology with applications in healthcare, so we'll look at some telemedicine advances, demonstrate ideas for improvement of resource allocation for the greater good for the most significant number of people. This means a utilitarian type of environment where we find out how we can benefit a larger number of people, especially during a pandemic when so many are affected. Let's talk about the description and significance of the research. The face of nursing care has changed greatly during the global pandemic. Almost every business we use, every aspect of our lives, wearing masks in restaurants, wearing masks in settings where we hadn't before. Today, for example, Sonia and I are wearing our mask and we're using appropriate social distancing, and I've had to social distance our audience today. So as you all can tell, we've asked everyone to sit 6 feet apart from each other. Currently, people in many parts of the world, their access to healthcare comes in different ways. There are hospitals, clinics, and rural settings. So we have to adapt to the changing landscape of healthcare delivery. The care has to be performed for other disease processes as well. COVID is taking a big picture right now, but we still have other disease processes. They need resources allocated to those. So we have to find a mutual balance. The difficulty that is presented by the widespread multifactorial virus can lead to a loss of resources with a greater number of patients. We decided on the cognitive continuum model. It's a blueprint for human decision-making skills. As we all know, triage is a decision tree where you decide which patient is allocated which resources and which patient would benefit best from the resources we have available, and the patient that would be likeliest to have a greater outcome based on evidence-based practice. So, I'll talk about the acute and critical care. At the time of this writing, every hospital south of Hattiesburg in Mississippi is on complete critical care diversion. This is the first time I've ever seen this in over a decade of being a nurse. The VA hospitals are being asked to take in non-veterans into the critical care setting because of the bed crunch. The hospital beds are being filled with COVID-19 patients, so we're seeing a developing trend in which patients are not wanting to present to overcrowded emergency rooms, the fear of being exposed to the virus, and limited seating. Therefore, these guys are staying at home, and a patient with chest pain might be having a STEMI and doesn't make it to the ER, and that certainly would not be the best outcome, as we've seen a lower rate of cardiac catheterizations because these people with chest pain are not presenting to the hospital. Patients are being moved from the ICU very quick, very fast. The census in the hospital are changing minute by minute. So your ICU patient becomes a step-down patient becomes a medicine patient, and they traditionally may not have been ready for that level of care. We're asking a lot of our nurses. The policies are being reevaluated regarding nurse-to-patient ratios. So each hospital is having to look at how many patients a nurse can safely take care of. You can't take care of the same number of traditional med-surg patients as you would during the COVID pandemic with all the donning and doffing, extra precautions, time to put on your PAPRs or N95s. In the emergency department, hotspot for the COVID-19 virus, super hotspot. The patients are less likely to seek care, sort of as I spoke about before, but it goes more in depth to that. Stomach pain, other ancillary comorbidities are not being addressed because the patients have almost taken on this aura of fear of the emergency room and medical health care providers. We've redirected our resources. So some of your senior ER nurses are having to go to ICU. even with minimal experience with ventilated patients, is still more experienced than, say, a med-surg nurse. So we've had to divert our resources, including bodies. Many hospitals have saturated ERs. We're using hallways for the delivery of care. We get calls from other hospitals saying that their ERs are full and they're treating in the hallways. So with the ERs being so overwhelmed, we've all heard the stories from, say, New York, where an ambulance is told if you have a patient with an advanced stage, advanced symptoms of COVID, they may not even make it to the hospital. It might just be that we do the best we can for that patient to have dignity in that time. So the resource utilization is a huge key point in these areas. Some ERs have recently had to divert patients to hospitals that are hours away. So we might be sending a patient 2 or 3 states away to get an appropriate bed or any bed for that patient. Staffing and resource utilization. So Mississippi currently doesn't have any safe staffing ratios. There has been policy and legislature introduced for this, but nothing stands currently. So we do not have staffing ratios. The decisions for the patient care also rely on fiscal responsibility also. So in terms, the dollar amount versus the resource that we need to use can come into play as well. Of course, patient care and delivery is going to be the #1 priority, but we do have to make some concerns as far as dollar amounts that we're spending. Experts are predicting a nursing shortage of 250,000 nurses in the upcoming years. And this is in direct juxtaposition to the number of nurses that we need to care for an aging baby boomer population as well as the global pandemic. Many nurses are also having to take extended periods of leave, 10 days quarantine, 20 days quarantine, that we have not seen in the past. So the global pandemic causes many potential nurses to also not want to enter the field. There's a stigma attached to the virus and the nurses who take care of those patients. We're losing nurses at greater rates, they're not being replaced, and nurses are deciding to leave the profession completely. So as I stated before, it's an inverse proportion. The number of nurses goes down, fewer people go to nursing school, the number of patients skyrockets as we have an aging population as well as a global pandemic that spreads very easily. Existing policy and recommendations. So our key stakeholders in this are going to be your nurses, physicians, and other members of the direct team. So this is the entire interdisciplinary team. If you want to look at ancillary staff, this is affecting dietitians, OT, KT, PT, your nurse practitioners, anyone that touches a patient. Their life has been disrupted by this COVID-19. The consumers are your patients and family members that we give care to. Only the most critically ill and severe cases are being admitted to the hospital at this point. Otherwise, we're trying to manage on an outpatient basis. The recommendations that we've come up with include safe national staffing ratios, clarity from the Board of Nursing on practice and competencies. What can nurses do? Are nurses practicing to their full scope? Are nurse practitioners practicing to their full scope? As we all know, there's recent legislature for nurse practitioners to be independent practitioners, so perhaps nursing could stand to be reevaluated and could perhaps have an expanded role. Forming a board at the hospital level for review and management of utilization of resources. Let's look at our expenditures, look at our resource utilization, form a committee, form a board. We can re-engineer and reframe the delivery of high quality care and try to make it more ideal in these scenarios. I'm going to turn over the outpatient clinic portion to my colleague Sonia, and let's continue.
Okay, I'm going to discuss outpatient clinics and urgent care centers. Many patients like using urgent care centers. For one thing, it does take the load off of the hospital emergency rooms, and sometimes those visits are just for, things that aren't severe enough for them to go to the emergency room. There's less wait times, emergency rooms are sometimes overloaded. Community members live closer to an urgent care than the local hospital. They'd rather go there. It may work out in their schedule. Consumers for these clinics are the primary care patients and those that require infrequent treatment outside of the setting of any major illness. These settings boast increased popularity. No appointment is required. They can walk in, be seen. go home, get their visit done. It's ideal for the busy, it's technology savvy for the consumers of today. Staffing and resource utilization. A recruitment piece for these clinics and urgent care centers is the hours. A lot of people like to work Monday through Friday with set hours. But even during this pandemic, that has changed. Nothing is set in stone as far as hours because facilities have had to extend their hours because of the pandemic and patients needing care. Nurses have to be trained quickly to identify the needs for changes in the level of care. Outpatient nurse may be the first healthcare provider to see a patient during a crisis. She's got to be able to assess that patient and maybe send them to the emergency room. Many clinical nurses are being pulled to acute care areas of care and being offered bonuses and incentives to do so. We've seen this in a lot of the local hospitals. When a surgery schedule might be slow or limited and they don't have a lot of cases, those nurses may get pulled to the acute care areas like the emergency room or ICU if they have the experience. Existing policy and recommendations. The stakeholders are the nurses and physicians working in the community clinic setting. Some facilities now, Memorial is a good example. They have urgent care clinics, they have diagnostic centers that are an extension of the hospital. And this helps serve the community even more so, especially during the pandemic. Some of these facilities they've had to set up as COVID clinics where they're doing testing and as well doing vaccines. Many urgent care areas have partnerships with hospitals. Some of the physicians will see some of their sicker patients in these facilities. Recommendations include urgent care centers provide access to the city to lessen the burden on the hospitals, again, overrun by the COVID vaccine situation. Nurse practitioners that are working in these facilities now may have to function in an expanded role to help treat some of these patients, whereas they don't have to overload the system in order to see a physician for their care. Rural care. This population is certainly close to the global pandemic as far as attention. Care of the rural patient is most often seen as the most difficult population to accept care. They've got some issues with technology and trust. They live far from the city. They don't like to travel into town, so they tend to want to kind of stay to themselves. So it's hard to reach that population. Many rural areas embrace stories, traditions, again, cultural beliefs come into play. Greater numbers of home health nurses and care in the home nurses are optimized because they go out and see these patients to deliver care to them. But with the global pandemic, there's limitations there. Rural nurses suffer from low levels of, rural areas suffer from low levels of education, and there are other socioeconomic factors also. Some of the rural community residents can't have that kind of healthy lifestyle. They don't do a lot of health promotion in their communities. In addition to medical services, they may not have goods and supplies that are offered, into their communities to help them self-care and help take better care of their health. Informatics and technology development. I believe telemedicine has been around for a while now, but because of the pandemic, it's even more so in the forefront. We see telemedicine in clinics. We're doing it in hospitals. There's telestroke, telemental health. There's different applications right now that are becoming more and more prevalent for use. Applications on a computer monitor, it offers face-to-face virtual visits. Internet resources that can record a patient's vitals and upload the information directly to the provider. Patients are becoming more technology savvy and possess greater access to a valuable tool of information. Everyone knows the term Google. Patients are using it, families are using it. It helps them stay connected with what's going on with their bodies, with their health. And rural nurses may be the only person visiting an older adult during the quarantine or during the pandemic. This makes it hard. We've got the restrictions, and rural nurses have to be aware of that when they're going out to visit these patients. Staffing and resource utilization. Recruitment of home health nurses relies on flexible schedules. Not only does this apply to home health nurses, but nursing in general. Right now, during the pandemic, flexibility, we've got to be flexible in our practices. Nurses now more than ever are equipped to communicate and deliver care digitally to patients aging in place. If we can get these patients connected and get them to use this kind of technology. The rural nurse may have to drive hundreds of miles per day and be equipped to deal with other problems in the home while seeking the resources held by DHS and older adult protection services. These are other factors that she's got to deal with alongside the COVID pandemic. In hospitals, many long-term care nurses have to work with even less staff. We're already strained as it is with the global pandemic, and we have to deal with understaffing. Existing policy and recommendations. The nurses, the physicians, and other members of the team are tasked with providing health care to these people living in rural areas. Currently, there's only one level 1 trauma center that exists in Mississippi. I think it's in Jackson. 3 coastal counties only have one level 2 trauma center. Consumers are the persons living in those rural areas that have limited access to care. Recommendations are going to include equal funding for each county for health care, and that certain medical services can be delivered within a standard number of miles. It's a challenge for every county, and resources are limited. Further study and limitations. The COVID pandemic has caused the U.S. and the rest of the world to constantly reevaluate healthcare delivery. It's not going to change anytime soon. We have to adapt. We have to constantly reevaluate, look at the research, and forge ahead to stay ahead of this pandemic. The prudent nurse is going to invest further time in evolving the trend of this global illness while still hosting a fair amount of time to the research. The nurses that work in medical major centers have to understand that sometimes the decisions may not make sense, but it is for the good of the facility, the patient, and themselves as a whole. We've got to work together during this pandemic, and flexibility is going to be the key. Of course, safety, but definitely flexibility in nursing right now is going to be paramount.
That's right, Sonia. I see that we are toward the end of our slides. We'll be giving everyone a copy of the references. I just want to ask, I know a couple of the people were wanting to ask a question. Clay?
Yes, I heard you discussing how the pandemic has had an impact on healthcare delivery, and you've mentioned several examples. What are some of the benefits of shifting to a more digital model of healthcare delivery?
I can answer that.
Sonia.
All right, so some of the benefits are you're going to reduce travel time. Individuals living in those areas that are far from their doctor's office or far from the hospitals will save time in driving. They'll save gas. They'll save money. It's beneficial because the telehealth now, as far as billing and insurance goes, there's reimbursements, so they're working through, those kind of issues that can come from it, and those visits, from what I understand, are not as much as a walk-in visit where you would actually see face-to-face physicians. Other advantages would be to have your records available to you digitally. Therefore, you're not waiting around trying to, wait for those records to be sent to you. And there's many other advantages to it, but that's just to name a few.
Does that answer your question, Clay?
Yes, it did. Thank you very much.
All right, we'd like to thank as a team everyone for being here today, and we're going to go ahead and wrap up this module. It's going to be uploaded to our Canvas, and we'll be distributing handout copies at the end of our class. Thank you all.